thank you very much for joining us for this, our third OncoAlert tumor boards. Today we are discussing a great case on prostate cancer, and our expert faculty will guide us not only in the presentation of the case, but giving us specific insights in the medical oncology, the radiation oncology, and urological aspects. Now, we are joined by a magnificent OncoAlert prostate cancer faculty, Dr. Neeraj Agarwal. He's a medical oncologist, editor-in-chief of ASCO Daily News, presidential endowed chair at Huntsman Cancer. Dr. Eleni Efstathiou, GU Oncology Section Chief at Houston Methodist Cancer Center. Dr. Axel Merseburger, professor of urology and chairman of the Department of Urology in Lübeck. He's an EAU board member. Dr. Sean McBride, chief of Manhattan Service in the Department of Radiation Oncology at MSK, focusing mainly on GU and head and neck. And we were expecting Dr. Simon Chaudhuri today, but unfortunately he could not make it. Our moderators are Dr. O'Kane, medical oncologist from Ireland and translational researcher in pancreatic and hepatobiliary cancers, and Dr. Westphalen, physician scientist from Germany and translational researcher in pancreatic cancer. I am your host, Gilbert Morgan, clinical oncologist from Texas, practicing in southern Sweden, and director of the OncoAlert Network. So now, without further ado, Dr. Merseburger, will you get us started?
So it's a case we see pretty often in clinic as a urologist. It's a 58-year-old male with localized prostate cancer, hypertension, otherwise healthy, and digital rectal exam discovered a hard mass, a CT, 3 tumor, PSA was 12.4, and surely in this case we recommended biopsies. We did biopsies and it was prostate cancer, Gleasons 4 plus 5, so a 9, so high risk. And conventional imaging revealed M0, so non-metastatic prostate cancer, and surely we will go into modern diagnostics in prostate cancer like MRI and PSMA PET at a later point in this short comprehensive tumor board. So in summary, 65-year-old patient with high-risk prostate cancer. So what do? We look at guidelines, what to do now. And there are several guidelines. And being a urologist in Europe, in Germany, I'm a big fan, and as Jill, as you pointed out, being on the board of the EAU, fan of the EAU guidelines, which frequently get updates just recently, and the printed version will be presented next week in Amsterdam at the EAU meeting to look at what is done best. And on the next slide, you have different recommendations from surgical treatment, from comments with regards to which surgical approach is the best. And I think the best is the surgeon has performed most often and is expert in, and about lymph node dissection and nerve sparing. Definitely in the case we presented here, neoadjuvant therapy, hormone therapy is not recommended out of clinical trial. On my third slide, which will be my last slide, and then I hand over to Sean with regards to radiation options we have. And my third slide shows the guideline recommendations from the EAU guidelines group on high-risk localized disease, exactly what we have here. And a strong recommendation is radical prostatectomy to selected patients with high-risk localized prostate cancer, and importantly, as part of a potential multimodal therapy. And that's what I tell to those young gentlemen with high-risk advanced prostate cancer, that the surgery might not be enough, that it might be post-operative salvage or early radiation therapy, and in combination with some kind of hormone deprivation. This high-risk disease, we should perform extended pelvic lymph adenectomy and not perform a frozen section of the lymph nodes to decide whether or not to abandon the procedure. So I think there's more detail published on that, but I think in summary, for this young, otherwise healthy gentleman with high-risk localized disease, this patient Surgery is a good, valid, recommended option. However, the patient needs to be informed on possible further treatment and that it might be not enough to just do the surgery. So thanks a lot for this, just setting the scene case, and I hand over to Sean. Thank you.
Hi, everybody. I'm Sean McBride. I'm a radiation oncologist at Memorial Sloan Kettering. So in keeping with Axel's focus on guidelines, I'm going to discuss briefly the AUA ASTRO guidelines, sort of the across-the-pond guidelines for localized high-risk prostate cancer. So in short, from a radiation standpoint, if we're treating this case definitively, we would recommend dose-escalated hypofractionated external beam radiation or combined external beam radiation and either LDR or HDR brachytherapy. The hypofractionated EBRT here could be moderate hypofractionation, meaning generally 20 to 28 fractions. That's what we would prefer, and that's where we have the data to treat. In terms of hormone therapy, in patients with high-risk prostate cancer electing radiation, clinicians should recommend the addition of long course ADT with radiation. That's 18 to 36 months. And the final critical question we always ask ourselves is elective treatment of the nodes. Assuming conventional and even next generation imaging like MR and PSMA PET show no evidence of regional nodal disease, should we electively treat the nodes? The AUA ASTRO guidelines equivocate a bit. We say may offer radiation to the pelvic nodes. In my own practice, I would tend to, in this particular patient, electively irradiate the pelvic lymph nodes. I just want to briefly talk about two trials that sort of inform us about the appropriate treatment for this case. One is the POP-RT trial out of Tata Memorial. This was a trial that looked at elective pelvic nodal irradiation in either NCCN high risk or NCCN very high risk patients. Importantly, these patients were PSMA PET staged and PSMA PET negative in the regional nodal basins. Obviously, they were M0. And this trial did show a distant metastases-free survival benefit. That was not their primary endpoint, but it was an exploratory endpoint. And it showed a robust DMFS benefit with the addition of elective pelvic nodal irradiation. The second trial I want to briefly mention is one of the arms of STAMPEDE, which looked at the addition of abiraterone in positive or N0 patients, assuming this patient's N0 on conventional imaging, and that's how STAMPEDE staged these patients, although they did use MR for local staging. If the patient was N0 and had two of either Gleason 8 to 10, T3 or T4 disease, and that could be MR stage T3 or T4, or PSA greater than 40, then there was a substantial overall survival benefit with the addition of abiraterone to standard ADT in high-risk patients getting treated with radiation. And I think in this particular patient, given the description that Axel provided us, the 65-year-old gentleman, we would I imagine the MRI is going to show EPE, and with Gleason 9 and EPE, he would fit the STAMPEDE eligibility, and we probably would recommend the addition of abiraterone to ADT with radiation. Obviously, that's a U.S. specific recommendation because we have Abby approved here. So thank you, everybody.
Yes, I think here it is very important to have a multidisciplinary discussion, and what we do with all those patients pre-treatment, regardless of hormone, of triplet, of radiation, we submit those patients and present those patients in a multidisciplinary tumor board to discuss best individual option for this patient, and then discuss. And we even in Lübeck have a clinic where we sit together with a radiation oncologist and urologist and simultaneously give advice to the patient. Thank you.
Before Neeraj, this is Eleni. Before Neeraj gets on, can I throw a bomb?
Absolutely. We love bombs.
Okay. So this is going back to slide 2, where I saw it loud and clear right there in those guidelines saying do not offer neoadjuvant androgen deprivation therapy before surgery, right? I'm going to bring in both Axel and Sean to answer it. So you're in this tumor board, and then you go back to your patient and you say, you've got these two options. And then the patient says, I'd like to have enhanced androgen signal inhibition. 3, 4, 5 months down the line, you're ready to pull the trigger on radiation because you're an ADT and ABI. Patient shows up and is like, nope, rethought it. I want to go for surgery. You've done your new MRI, it looks great. So you take it back to tumor boards. What do you do then? That's kind of something we deal with every day.
So, Eleni, if I may start, having the robot waiting here, no, I would have no problem offering this gentleman prostatectomy, as we know from trials right now, recruiting even like with doublet combination with apalutamide, the Proteus trial, for example, that it's safe and we've done surgery and it works. It's just hasn't proven just in the surgery field that it prolongs overall survival in a prospective fashion. So we don't know that, and that's why it's not recommended by EU guidelines. And we have published evidence that even in high risk, we can wait up to 6 months. This is data out of the COVID times, and don't have altered postoperative pathological result. Thank you.
Great. Sean, I'm going to throw another little bomb at you. This young man.
Eleni, go ahead.
Yeah, 45-year-old, by the way. He's got a BRCA2 germline. Back to you.
Yeah, so I think there's two variables at play in that particular case. One is very young age, and in very young age, we probably would tend to lean, regardless of BRCA status, we probably would tend to lean towards RP in that case. I think if let's say he's a 55-year-old with a BRCA2 mutation, we have data from other subsites, namely breast cancer, that having being heterozygous germline for BRCA2 mutation doesn't increase the risk of substantially increase the risk of second malignancies or acute toxicity in these patients. So I would be comfortable with a radiation-based approach for a patient with a BRCA2 mutation. And you could even argue that maybe they'll be a little bit more sensitive to to radiation-based therapy.
No, I love that because, our fear is this guy, if God forbid, 15 years later, would you get another? Because this is also multifocal disease, and this is really at the crutch of my question. But you seem comfortable going for radiation on the 55-year-old.
I would. 45-year-old, I think there's more of a question. That was,
right.
What you had mentioned. But 55, absolutely, I'd be very comfortable with it. And I've treated BRCA2 patients with BRCA2 mutations with radiation-based approaches, and anecdotally, have had positive experiences.
The great conversation. Hi, this is Neeraj. Really enjoying the overall conversation and learning a lot. So, Eleni, how about the risk stratification? Sean just finished talking about the STAMPEDE trial. So do we discuss a bit about PSMA, or we should go ahead to talk about what if this patient develops low risk, low volume, metastatic castration sensitive prostate cancer?
I think you do the honors with PSMA, or whoever wants to do the honors, right? I think it's you. It's all on you. We got to hear you.
Okay. All right. So, what if we had done PSMA scan here? And PSMA had shown, of course, we don't have the answer here. None of the current trials in hormone-sensitive metastatic prostate cancer setting has used PSMA scan as an eligibility scan. All of them have used conventional scans. So a question always comes, and we will discuss this question after our presentation of the case. What we had done if patient had, metastatic disease on the PSMA scan. Obviously, advancements in imaging allow for improved accuracy in diagnosis. And we have seen field evolving from the FSC, BC PET scan or choline scan to PSMA scan, which have taken the center stage now. So I will like to, for the sake of discussion, I'd like to take a step back. And this is slide number 12 for the audience and for my panel members here. Let's go back and assume this patient did not get abiraterone per STAMPEDE data. And this patient was diagnosed, 5-6 years ago, received radiation therapy, local concurrent androgen deprivation therapy. And now a patient has developed low volume metastatic castration sensitive prostate cancer. So again, this patient has received radiation therapy in the past, has been followed, or let me rephrase, let me let me basically say this patient comes to us for the first time, had never received local therapy, is developing has come here, PSA was 12.4, biopsy shows prostate cancer, Gleason 4+5, imaging studies shows, traditional scans show M0 disease, PSMA scans show M1 disease. What do we do? So let's go to slide number 13. And we tweeted this slide in the morning about what are the options. So case discussion is a low volume, newly diagnosed metastatic castration-sensitive prostate cancer patient. And we have the option of treating this patient with these are the following options: ADT plus radiation therapy to the primary tumor, ADT plus apalutamide or enzalutamide, ADT plus docetaxel chemotherapy, ADT monotherapy only, or ADT plus radiation therapy plus one of the novel hormonal therapies such as apalutamide, enzalutamide, or abiraterone. So what should we be doing? And please remember, patient does not have metastatic disease on conventional scan and has M1 disease, low volume on the PSMA PET scan. So do we do a discussion here, Gil, or we should just keep moving? Yeah, so I would start with Axel, who was my co-steering committee member on the Titan trial, obviously has led many studies, but we had the chance to interact on this study specifically. None of the patients were PSMA positive, Axel. What do you think? What should we be doing here?
Yes, Neeraj, thanks for trust. And I think here, having in mind that this gentleman is a very young patient, 58, I would go for the all-in situation. We have data surely supporting ADT backbone and NHT. And as you said, from the Titan trial, it has shown that even like in low volume, low risk disease, the patient benefit with regards to PFS and overall survival. So apalutamide, and also what we know from Archer's enzalutamide is a good option. Abiraterone in Germany wouldn't have the label for the low risk, low volume situation, so it would be out. Otherwise, I would have ticked the last option because I also like radiotherapy, as we'll probably later discuss that there is evidence from the STAMPEDE program that radiation of the local of the prostate makes sense, whereas no proven data is there for surgery. Thank you, Neeraj.
Yeah, thank you very much. Eleni, I will probably pull you in on this one, slide number 14 for us. This is the basically overall data for low volume metastatic disease patient population from the STAMPEDE trial, from the ENZAMET trial, and from the Titan trial. And again, Archer's trial also had very similar data, but just for the sake of discussion, we wanted to make sure we represent abiraterone, enzalutamide, and the apalutamide data. And all these three trials show improved survival. Obviously, this is docetaxel with STAMPEDE, which also showed that radiation therapy to the primary prostate improved survival in a subset of patients who had low volume disease. Trial was overall negative, but low volume subset pre-specified was positive. And then enzalutamide trial, as ENZAMET, Arches, Titan didn't allow radiation therapy to the local prostate in a definitive fashion. So we have this data, and then we can see the Titan trial data. We are talking about a median survival of these patients, which is going to be in 7, 8, or 9 years, I think, with Titan, as we see the data maturing. Over next 2, 3, 4 years, we are looking at 70 months plus survival time for control arm, and who knows, 2, 3 more years with apalutamide. We'll see how the data evolve. So Eleni, what do you think? What should we be doing? Radiation therapy to the local, to low volume metastatic hormone sensitive prostate cancer? Should we be offering to all patients, even though the data only come from STAMPEDE docetaxel trial and not from ENZA or apalutamide trials?
So Neeraj, I think you're kind of egging me on here, and you know I'm gonna act like the mix of Texas and Greece that I am, and tell you this is the time for me to go for that kitchen sink. You know, I've got this front door policy of running on all of my patients. We're going to talk about it later, germline and somatic. And especially when I get a young man who arguably you're going to say, this is PET PSMA, don't go crazy on me. I'm going to say, I'm going to use obviously a doublet. I'm going to do the RT of the prostate. And I want to hear Sean tell me why I shouldn't. And I know that at some point even Pete Ost was on and listening on to us. I'm going to throw something worse at you. I'm going to ask you when I'm going to stop this treatment because I don't want my man to be forever on this doublet. And am I going to go for metastasis directed therapy, which is the big question that's going to come on that tumor board we're having in real life setting. So I'm going to send it to Sean now.
I mean, I would be a little bit of a purist here because as Neeraj stated the case, this is conventional M0 PSMA M1, oligo M1. So for this patient, as Neeraj also alluded to, none of the trials which defined our standard of care, except for POP-RT, included PSMA PET staging up front. So for this patient, I think we would treat him like a very high-risk localized patient. Now, from the radiation standpoint, that makes it relatively easy because the treatment, from my perspective, would look quite similar. It would be radiation to the prostate. Now, if we're treating him as conventional M0, I would electively treat the nodes and give him ADT-ABI for approximately 24 months per STAMPEDE. I just don't see in this case, even if he was conventional oligomet, I don't see the data here arguing for the inclusion of docetaxel up front. Maybe you could make that argument if he's BRCA2 mutated, but just in a person who has no germline mutations, I would treat per more of a standard of care for convention. If he's conventional
Right.
M1, RT to the prostate, no elective pelvic nodal treatment, and then ADT-ABI for how long? At our institution, we probably push it for 24 months. Obviously, you could do continuous too.
Okay.
I think the real. I was just saying, Eleni, I think the real. Oh, go ahead.
Just one thing. I didn't say docetaxel. I asked you about metastasis directed. Docetaxel is not in part of this discussion for now.
Metastasis directed, again, we don't have any data for MDT
Exactly.
up front in these patients. Now, how that plays out in practice, the patient's really pushing you, the toxicity is de minimis. Certainly I have in cases done MDT up front, but I'm very clear with the patient that we don't know what the benefit will be. The downside risk, I think, is small.
This is a fantastic discussion. Just loving every single bit of it. So, Eleni, my take on this one would be, again, as we continue to evolve our practices based on new data coming on a monthly basis. So this is a patient, as Sean, if I got you right, this is a patient who has negative metastasis on conventional scans, has a localized high-risk prostate cancer, young man. Your approach is definitive radiation therapy and treating the patient in a way you would have treated, or the investigators treated on a STAMPEDE abiraterone localized high-risk trial. Is that correct?
That's correct, yeah.
Okay.
And I would, not to speak for Axel, but I think he would be justified in saying he would take the patient to surgery too.
Yes, fully agree.
Well, we have the SWOG trial going on. So that will hopefully answer that question, whether surgery has any role in low volume, if you will, low volume high-risk prostate cancer, localized high-risk prostate cancer.
I'm concerned with that one, Neeraj, because now that we have the STAMPEDE data, right, it's kind of skewed more for high volume, but it's a great thing to look forward to. I think we needed that non-inferiority type of trial that would look at the RT use versus radical prostatectomy, kind of a small boutique-ish type of trial that would help us understand, because of course of the heterogeneity of the disease. But let's see.
I agree with you 100%. I think we have all similar concerns that patients do not have the equipoise and low volume disease to be randomized to a trial where low volume patients may not be deemed fit for nothing as far as radiation therapy is concerned. So low volume patients are getting radiation and high volume patients are being recruited to the trial. There's always a possibility, but randomized trial is a randomized trial, and I agree with you. We are waiting anxiously to see the results of the trial. And I think slide number 15, Sean already addressed the question, would you consider radiation therapy to the prostate of this patient who has negative metastasis and conventional scan, small volume disease on the small volume metastasis in the PSMA PET? Answer is yes, radiation therapy will be considered and abiraterone will be given to the patient as these STAMPEDE investigators did. So I think we'll move on to the high volume disease. Eleni, stage mic is to you now. Slide number 17 or 16, I think. Thank you.
I think it is 17. Thank you so much.
Yeah.
Gil, I wanted to get the take of the European, both Neeraj and I practice. I mean, I can practice both sides, but we practice dominantly in the US.
Very interesting to listen to you, and I can only echo you. I think this is a way we should go. Even though I really like operating, I think here we need to go by the guidelines, we need to go by the evidence. And as said, Neeraj, we are waiting for the SWOG trial until we have a clearer picture on whether or not surgery competes with radiation therapy. Could you tell the audience when we can expect the result?
I don't think we know yet. Trial is still accruing very well, so hopefully in the near future. But I don't think I have the exact dates in my mind right now, right off the bat.
So, Axel, do you want to make any further comments, or should we just push through to high volume?
I think we can push through to high volume. The only comment, I wouldn't go with ARBI since it wouldn't have the label here in Europe, but I would rely on the data we have from Titan using apalutamide in the situation where we only need one MET, and this patient had a proven metastasis in the bone, and also enzalutamide would be, I think, a good option. Whereas even though we saw the ENSAMET data now at the ASCO, I wouldn't go with docetaxel in this low risk, low volume patient with only detected disease in PSMA PET. Thank you. Comment.
So just to sum it up, first of all, we have established that Neeraj is the only one of us who can truly multitask. But with regard to, and it is true, 100%, I can attest to it. But with regard to the patient case, I think we have a consensus that we would try to be proactive and treat him as an equivalent to a STAMPEDE case patient. And that is what it reflects. If you look at the eligibility of STAMPEDE, this would be the man who would look on the surface on conventional imaging as not having meds, but upon PET PSMA, you would pick something up, one or two meds. So we would include local treatment of the primary, combined androgen blockade with enhanced androgen signal inhibition. And we said ABI, ENZA, APA are on board. And I bet you soon enough we'll have some data to consider DARA. So we've got that. There's no consensus, even though it is practice, for metastasis-directed therapy. And Sean said it 100% right. We are looking at what would be your minimal safety concern. So with that in mind, maybe could pass. So let's go on to the consideration that this would be a gentleman who has high volume disease. Now I want to preface it that we're looking at slide 17. I want to preface it. We would all agree that the word high volume or low volume, which is more of a phenotypic event, it's a dynamic event. And it's actually how you're looking at the patient at what time point. I could argue that it's more of a surrogate of the biology of the disease. So if you get lucky enough, you could pick up the aggressive disease early on. Because this is what we don't know. You may be looking at something that looks like low volume, but is in the making of a very aggressive disease. I'm just pointing that out to just showcase how limited our tools are to understand which one is going to be the aggressive disease. And again, stress the importance of potentially upfront germline and somatic sequencing because it provides a little bit more insight into that. So slide 17, when you'll see it, it actually speaks to that treatment intensification with doublets. the things that we started looking at from 2014 all the way to 2020. There's no question, and there have been multiple meta-analyses to suggest that you don't even need to overthink it, and that was till 2021, but just go for a doublet. And at that point, we were saying it can be ADT plus docetaxel or ADT plus a novel hormonal androgen signaling inhibitor. Now, things have changed a little bit. We need to be careful. So, if you go to the next slide, let's look actually at the treatment intensification with triplets. It started with PEACE-1, continued with Arisens, and Enzamet gave us some data just now at ASCO, which have not been included here, but I will make a comment because I loved Ian Davis's presentation. So the treatment intensification for de novo metastatic high volume disease seems to be clearly favoring the potential consideration of a triplet. However, I will get to that in a minute. We still don't know where docetaxel really comes into play, but we're playing it safe and saying, okay, this is truly aggressive disease. Let's go for it. What Ian showed was that for the first time in that first 2 years of losing about 20% of your patients who have high volume de novo disease, you're getting a dent by a triplet. If you go back all the way to Charted, you will see, because that was a very high volume disease setting as well, that 20% of patients, same with STAMPEDE, 20% of our patients are lost to the disease within 2 years. And that's really bad. These are the really bad players as tumors. Now, Ian showed it and showcased it during his presentation. There's a dent there. And just for that, it's worth considering that triplet for those men who can take it. Now, the next slide that Neeraj and his team put very nicely together is the problem. The problem is we've been just looking at adding on to docetaxel an enhanced androgen signaling inhibitor. So if we considered, when these trials started, docetaxel plus ADT, the standard of care for a couple of years, that's what we were doing. We were adding on. We did not do the inverse, add docetaxel to enhanced androgen signaling inhibition. So what we know to date is we need that trial, but we need to play it safe, especially for these men who have aggressive disease. So, slide 21, put together, again, very wisely by Neeraj and team, says no role for ADT alone. And I will be, again, very passionate and say it is unethical to give ADT alone, except in those very exceptional cases, men with heart failure, blah, 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 that we know, unfortunately, are going to pass due to another comorbidity. And doublets of androgen deprivation plus an enhanced androgen signaling inhibitor, however you call it, should be used for all patients. Okay, we can talk about liver mets, lytic mets. We'll go to that during discussion. But this is an important point. We've got now 3 trials. One clearly, Arisens. Another 2 kind of indirectly telling us ADT plus docetaxel is not enough. It is not enough. If you're going to go for that, you need to go for a triplet or leave out docetaxel and put an NHA. I mean, if your gut feeling is leading you to docetaxel, put on board an enhanced androgen signaling inhibitor. Of course, our patients are living longer. We saw that. Kareem showcased it during GU ASCO and before presentations. And now it is time to optimize survival while we're maintaining the quality of life. What we're trying to say is, we can't cheer along saying, well, patient did well on his treatment for metastatic disease, but died of cardiovascular disease. That's on us. And I'm not saying that necessarily our drugs are causing it, but we become all of a sudden the gatekeepers for these patients. So if we can't handle it alone, let's get some multidisciplinary teams working with us. I like that art of medicine. It's an art and a science. It makes me feel Neeraj more like a wizard. I really like that. Now, I added those final little slides there because I can't stress enough the importance of a system-wide approach to genetic testing, both germline and somatic. I understand limitations. I get them completely. we may have them on the guidelines, but we don't have availability. There's cost issues, but at least put it on your front door. Do it so you can save the lives of other people in the family. I've picked up germline mutations even in intermediate risk disease, and that can help this man be saved from other potential primaries. And when it comes to somatic, it's a big discussion because a lot of folks say, well, I'll do it later. I like to do it up front because if I know there's even a somatic DNA damage response gene alteration, I know this is a bad player. And I like to know what is the TMB status. I also want to know if there are other events that may be coming into play, B53, RB lost. And yes, we'll have in a minute the discussion regarding, and I will take it back to Neeraj, discussion regarding the value of these. So back to you, Neeraj, for thoughts.
Yeah, thank you, Eleni. Again, enjoyed the discussion a lot, especially your views on triplet versus doublet therapies. And I really cannot emphasize upon this enough that we have to think about de-escalation in the right individuals so that we can give a chance to our patients, especially the younger ones, to regain some quality of life over long term when the survival may be exceeding 6, 7, 8, 9 years. So coming back to your question about somatic testing guidelines, I make it very simple in my clinic. We do order comprehensive genomic profiling for every single patient with locally advanced or metastatic prostate cancer. I know NCCN guidelines cover many of these anyway, but I've realized, based on my experience from the PROfound trial, when I was involved in the conduct of the PROfound trial, we could not really screen 30% of the eligible patients because we did not have enough tissue or sufficient quality or quantity of tissue left for them to allow even screening of those patients. Those patients were otherwise healthy, eligible, good lab test. They had metastatic prostate cancer. They qualified every criteria, but they did not have tissue available. And I learned firsthand that if I do not send out the tissue for comprehensive genomic profiling on the day one, when I see the patient for the first time, I'll miss the opportunity. Now, germline testing is definitely guidelines endorse germline testing for all patients with advanced or metastatic prostate cancer. Number of genes have been, what genes to cover really varies from guidelines to guidelines, but then I feel very fortunate to have fantastic team of genetic counselors, accessibility to genetic counselors in our institution. This being University of Utah, where the discovery of BRCA1 and BRCA2 happened. The genetic counseling team is at the forefront of these testing, and I feel very good about having that access here. Having said that, the pandemic has really expedited the availability of genetic counselors across the board. So I think anyone can have access to genetic counseling as well as germline testing. And without getting into the detail of the type of genes, I would say send the patient to the genetic counseling when we see them for the first time. So that is my take, Eleni. Thank you very much.
That's great. Actually, Neeraj, what I do, because we don't have the privilege, and breast cancer is always ahead of us. They take all the geneticists. What I do is I do upfront day one germline testing, sharing with patients some information. And once it comes back positive is when the heavy duty genetic counseling occurs. And here in the US, we can do it. But Sean, I wanted to get the East Coast view of life and then to Axel to give us the European kind of more hard reality on things.
I think just like Neeraj, we're quite aggressive in running next-gen sequencing on certainly our de novo M1 patients and on our even on our high risk, very high risk localized patients. I just wanted to ask a question of you, Eleni, you, Neeraj, and I guess Axel as well. What kind of NGS finding, next generation sequencing findings, would you think would be ripe for a trial of de-escalation? Maybe just ADT alone for de novo metastatic, something like that.
Yeah, right now we do not have the data to allow. So great question, Sean. I think about it all the time. I wish I had something which would have allowed me to de-escalate, especially in this young man, where I really want to have a real break with the normal testosterone level. And I do not think we have the data. We have the molecular markers to support that kind of approach right now. Hopefully soon. I
can
look
only
forward to
echo
what
here.
Eleni says. Yeah.
Yes, Neeraj, and from my perspective, I think so far here in Europe, we have olaparib approved in mCRPC for BRCA1 or 2 positive men in mCRPC. So I think that's where I would test, and I convinced the man to get in early testing in mHSPC when it comes towards progressing to mCRPC. Otherwise, we don't have a label, and I think it's we have molecular tumor boards to look at other options, but I think for the broad population, I would stick within the label, and the rest surely is highly exciting and interesting, but something for the future, and probably a discussion we should have in one of the future Twitter tumor boards we're having today to talk on like molecular markers and how they influence our therapy. Thank you.
Yeah,
Sean,
I think I'd like to
yeah, go
rephrase,
ahead.
Eleni, sorry. I just want to make sure I got the question right, Sean. You were asking, do we have any molecular markers to allow us to de-escalate treatment in our patients with metastatic castration-sensitive prostate cancer? Is that correct?
No, I was asking more in the future. What next gen sequencing information do you think would be what mutations are most ripe for trials of de-escalation?
Got it. Thank you very much. Yeah.
So this is a great research board question, Sean, and I love it because it comes right around the alley of my great interest that you have too. High volume, high risk disease that arguably localized is more enriched for an aggressive phenotype. What we already know from our phase 2 neoadjuvant is that you get primary resistance to androgen signal inhibition in about 40% of those men. So all those big neoadjuvant trials that are ongoing, they're going to run into a wall with that 40%. The problem is dual, is who is exquisitely sensitive to androgen signal inhibition and who is not sensitive at all. And you're just adding toxicity, especially in that. So you got to look at both ways. And another way to do it in a trial that I'm kind of doing now is looking at those men who have the recurrence and actually selecting out the prognosticators going back to your diagnostic biopsies. So it's a very convoluted question, but I love it. It's great. So I'm going to turn it to Jill or our moderators to talk to us about, do we have any questions we need to address? Because I know we're running low on time.
Hi, Elaine. Thank you so much. I mean, everyone, this has been an amazing discussion, and quite honestly, I think we're just kind of letting you all go at it because this is such an amazing back and forth, and this is actually the meaning behind the tumor boards. And I think we are learning with every single tumor board that we do, and you all have just taken it to another level. So I think we are going to respect this amazing, amazing dynamic that you all have going on, and just open the question up, but for the faculty. If the faculty has questions for other members of the faculty, just to address that.
So I would ask the question to the panel here. I see this pretty much on a weekly basis, this dilemma, this question raised by my patients, by our co-workers and trainees. Patient has PSMA PET positive disease, low volume or high volume, but it's PSMA PET positive disease, but has no evidence of disease on conventional CT scan and bone scan. What is it okay to delay treatment of these patients with systemic therapy if patients are completely asymptomatic? Rephrasing the question, are we not talking about the same patient population who were, until very recently, and who may still be, being treated with intermittent androgen deprivation therapy as monotherapy when the PSA is 10 or more, and you stop ADT when PSA is less than 4. What is the harm in using that approach in PSMA positive but conventional scan negative disease?
Raj, probably everybody is quiet now because we don't really have solid evidence in this situation with the new modern imaging. We are just trying to explore. So I think translating this to the trials we have, I think intermittent treatment with the old standard, old-fashioned is vintage treatment, and I think it's out. It's not. It should not be done anymore, since we have seen that men can really extensively have a longer overall survival when treatment intensification is performed. And I believe this modern imaging, so I would go definitely for intensification and would need more trials. And if best scenario would be biomarkers. Thank you. I need to apologize. I need to leave. Thank you for this great discussion.
Thank you for the answer. I heard that intermittent therapy is not a appropriate option in this one from Axel. Sean, Eleni?
Yeah, Neeraj, you're talking about a recurrent disease, right? I got it right.
Yes,
This is
recurrent
recurrent
disease.
So a couple of years ago, before pandemic, right? Because pandemic years don't count. So I presented with the team, we had done this intermittent combining Abby plus ADT versus ADT alone. And we showed that you kind of were able to get back testosterone quickly, but you would get more protracted periods of time off of treatment, right? That quality of life that we're referring to. And this becomes important, but it does not solve the issue because the disease recurs. And you have some disease that now you have unveiled. We knew it always, we didn't have the tools. So it goes back to the need for a trial, because if you go back to Klotz's paper, Klotz et al., back in New England 11 years ago, what we saw was intermittent versus continuous, that non-inferiority per overall survival had to do with the fact that on the continuous arm, you lost more men due to side effects, cardiovascular events, and not due to prostate cancer. On the intermittent, you lost due to prostate cancer. So I think it's a research question that needs to tease out those men who are in danger of dying from that met that you find eventually dying, right? Or compromising quality of life. So the truth is somewhere in the middle, because there are those men who can for years survive the disease without a need of more aggressive intervention.
I would say, Neeraj, I think that's a great point by Eleni. Just taking your case and just looking at the low volume. So you've got a patient who has primary progressive prostate cancer that's M0 on conventional imaging and M1 on PSMA PET. I would argue that here is where we have that sort of niche is where we have some data for the use of MDT. We have Oriole and we've got STAMP, where in those patients, a substantial number can be ADT free for an extended period of time with just metastasis-directed SBRT, with little in the way of meaningful side effects, and then avoiding upfront ADT. I think that would be an option in the low volume M1 by PSMA PET only primary progressive patients.
Agreed. I think it's time to wrap up. Back to our...
Excellent. I think so too. Thank you also very much. Again, not only the case, but the amazing discussion was great. Now, what I wanted just to do, we normally end up the tumor boards with just a 20-second wrap up from each one of our faculty members of what we should take home for this case. We can start off with Eleni.
I'm going to let Neeraj and Sean go with the pearls of wisdom, but I'm going to say something quickly.
I was doing my Texas thing, Eleni.
No.
I was trying to be chivalrous.
I know, but it's also very gentlemanlike. But quick comment for those listening in. There's nothing more invigorating than getting on discussions with peers, with other people who have the same passion as you for GU malignancy treatments and in general treatment of our patients. So don't go at it alone. Reach out to people, have these discussions. I mean, I learned so much today, and thank you all.
And these are some of my favorite discussions. I've had a great time with Axel, Neeraj, and you, Eleni, here talking about these cases. It's nice to see how experts in the field approach these kind of controversial cases. I mean, my take home would be, you know, in the high risk localized disease, you have RP and RT options that I think are largely equivalent in terms of outcomes, but obviously have different side effect profiles. I think the other big take home for me is the strong support for prostate directed RT in the low volume metastatic disease. I think that's now sort of a well established standard of care.
I agree with everything. What a fantastic discussion today. So much to learn from my esteemed colleagues. And Eleni, I just still cannot take it off my head. De-escalation. Where should we be thinking about de-escalation? And I hope we have trials coming up where we think about a possibility of stopping androgen deprivation therapy so that we can allow some periods of normalization of testosterone in these men, especially young men, who are going to live with their metastatic prostate cancer for years, hopefully decades in the near future. I also keep in mind what you said. There are some patients who are not going to make it past first 2 or 3 years, the most aggressive disease patients, and how to recognize them up front so that we make sure to use the most intensified therapy in those patients. And I think I would conclude by saying biomarkers will continue to play a bigger role, much bigger role, hopefully in the next 2-3 years for these patients.
Excellent. Thank you also very much for joining us today. I can't even thank our amazing faculty enough, our wonderful moderators, and for all of you listening. It really appreciate, as always, OncoAlert appreciates the support. We are completely colleague driven, as you could tell by me not being able to tweet and answer questions at the same time. We receive no support for these tumor boards, and we like it that way. So a reminder that today's tumor boards will be released at the end of the week. We will do it as a video presentation on YouTube with the slides. They will come out with the podcast, so you can listen on your way to work. And as always, you can just go on Twitter and just type hashtag OncoAlertTB. That's OncoAlertTB for tumor boards. So until we see each other next time, we'll just continue talking on Twitter. And I can't echo Eleni's message of reach out, especially on Twitter. I mean, come on, we have like the best people in our field at just a click away. So let's just go ahead and use that, because that's what we're here for. So until next time, thank you all very much.